I think there were some interesting updates with regards to myelofibrosis. Thinking about this from the therapeutic perspective, I think two studies stand out. One, there was the initial report of data with a calreticulin targeted agent from Incyte, and this is the first report of the activity of this agent in patients with myelofibrosis. And that study showed that there were some interesting changes in that there were reductions in things that I would say are traditional markers of disease response, like spleen size reduction and symptom reduction. But one of the interesting things was that there did seem to be an anemia benefit signal. And there were some really interesting molecular studies presented separately from the main clinical story that seemed to suggest that there was, some depletion of the calreticulin driver mutation within the hematopoietic stem cell and progenitor compartments. So these are early data, and I think there's definitely a lot of heterogeneity in the data. But that is a reflection of this being a phase 1 dose escalation study, also being a reflection of the heterogeneity of the disease. But I think these are very interesting data, and of course we need to see longer term follow-up with perhaps a more homogeneous patient population and treatment regimen. I think the other study that is to some degree unique was the 96-week follow-up of the MANIFEST-2 study, and this was the phase 3 study of ruxolitinib versus ruxolitinib and the BET inhibitor pelabresib. And this was the longest follow-up of a phase 3 study in myelofibrosis, which is really important, I think, because most of our studies read out at week 24, and that is historic in some ways because that's how initial JAK inhibitor studies read out. But one of the key questions and challenges is understanding how durable are the effects that we see with new agents. And that's a critically important question because if you're adding a second agent to a JAK inhibitor like ruxolitinib, there's likely going to be a greater cost, but also potentially, more toxicities with combination therapy, although not necessarily. But what the 96-week data showed was that with regards to spleen response, the combination of ruxolitinib and pelabresib continued to have a deeper response and a more durable response than ruxolitinib monotherapy. And that's important because we do want to see durability of the response. Symptom reduction numerically seemed to favor the combination, as did improvements in hemoglobin. And there were no, major additive toxicities when using the combination versus ruxolitinib. And finally, there had been some early concern about an increased risk of leukemic progression in the combination arm, but by week 96, it looks like it's numerically very much equivalent between the two arms. This is a study that is addressing one of the major unmet needs in patients with myelofibrosis, which is anemia. And, the study did show that there were certainly some benefits to patients in terms of improvement in the hemoglobin, reduction in transfusion burden, and to some degree freedom from transfusion burden. And I think one of the points that's important here is that reduction in transfusion burden to me is a very clinically meaningful endpoint. If we take a patient who is getting transfused, let's say once a week, we cut that down to twice a month, let's say. That's a significant savings in terms of the patient's time and an infusion share. So I think those are some early interesting results from the study. I think a lot of interesting things. We'll see probably further data, with calreticulin targeted agents. There are other agents in development, I think, that are also calreticulin targeting agents. So we'll see what happens with those agents. We're hopefully going to see some readout from some of the ongoing phase 3 trials, like the study of selinexor. I think that we may see further follow-up data from the Manifest study, which I think would be really important for the reasons that I've cited. And, I think there are some other agents too that have looked interesting. Cyclin-dependent kinases are an area that, our group has focused on, and we presented data at this ASH in a poster with a combination of ruxolitinib and a CDK4/6 inhibitor called abemaciclib, which is FDA approved for breast cancer, which had very, very encouraging results in terms of spleen reduction. So that's proceeding to a phase 2 study. There was also a new JAK inhibitor that was presented at this ASH that actually has cyclin-dependent kinase inhibitory activity. And it was a randomized study versus ruxolitinib that actually showed substantial benefit in terms of spleen and symptom response over ruxolitinib monotherapy. And of course, we will see hopefully data from some other novel JAK inhibitors in the coming year. So, an exciting time for myelofibrosis research, no doubt.